For those of you who don't know me, my name is Shoaib. I'm a radiology registrar, and I will be taking you through some of the basics that you need to know for your exams, and hopefully simplify X-rays because they can be quite difficult as a student. Let's hop into things. But before I do, I just want to let you know about our website. And as I'm sure you all know, we have a question bank. It's a case-based question bank. So rather than jumping from topic to topic, you're really taken through a particular diagnosis in a lot of detail, right through investigations, through to pathology. So I think this is actually the best way to learn. And with each question bank, with each question and each topic, we have an associated textbook section. Again, quite detailed, so please do check it out if you haven't already. And before we jump into things, I wanted to touch on our live event that me and Azim are running on the 12th and 13th of December. So this will be a revision event for SBAs, mainly aimed at final students, but still relevant for sort of penultimate years and third years, etc. And as I said, it's a paid event, but you have a discount if you're a premium member. And just to go over what we'll be covering, on the first day, it will be predominantly focused on medicine, so things like cardiology, respiratory, renal, etc. And on day 2, we'll be covering surgery, and that will be led by myself and Azim. So if you want a sort of crash course into medicine and surgery, please do attend, and you can sign up on our website, BiteMedicine.com. Okay, let's pop into things now, because I've wasted a lot of time, but I want to sort of get through this fairly efficiently. So for exams, you really need to know your chest X-rays fairly well, but to be honest, the things that will come up in your exams will be pretty straightforward. They're not going to ask you anything which is super difficult. Because even as a radiologist, and my consultants always say this, X-rays are the most difficult imaging modality to interpret. You only have one image, or maybe 2 if you've got 2 views. It's not like a CT scan where you have a 3D representation. X-rays are very difficult. So don't feel disheartened if as a medical student you really struggle with X-rays, because so do consultant radiologists, and that's absolutely fine. What we are going to go through today are the technical aspects of chest X-rays, a methodical approach of going through X-rays with some cases. And rather than covering the anatomy of a chest X-ray separately, I'm going to go through cases. And as we go through the cases, we'll cover the anatomy, as well as the pathology, of course. This is a 2-part lecture. So today we're going to focus on chest X-rays, and for the next lecture, which Azim will probably do, we'll be focusing on abdominal X-rays, appendicular X-rays, so that's things like your limbs basically, basic CT that you need to know for your exams, and that's mainly CT head, looking for brain bleeds, and again, basic ultrasound looking for gallstones and renal stones. So that's pretty much everything you need to know for finals in a nutshell when it comes to radiology. Hopefully this won't be longer than an hour, and the slides will be going up if they haven't already, and the recording will also, of course, as always, be uploaded. Okay, so if I pull up Menti, don't answer that question just yet. Which of the following is the best way to assess heart size on a chest X-ray? So if you go to menti.com and type in the code 4704020, hopefully you can answer that. Let me just look at some of your questions. So not sure if you're going to go through this, but can you explain how to differentiate toxic megacolon from large bowel obstruction? We'll go through that in the next lecture. It's a good question and something we'll certainly cover. So which of the following is the best way to assess heart size? AP, lateral, PA, supine, or upside down? Good. The answer is PA. If you don't know what that means, don't worry, because we will discuss. So PA means posterior anterior. So the patient's back is to the imaging source. And this is the best way to assess for the heart size. AP is the other common position of patients, and that gives you an inaccurate assessment of the heart size. So some of you said AP, but why do we not use AP? What's the problem? Does it give a bigger or a smaller representation of the heart size? Exactly. So it makes the heart size look bigger than it actually is. So you can't properly assess for something like cardiomegaly. So this is how chest X-ray acquisition works. You have an X-ray beam. It fires a bunch of X-rays and they fan out. Okay, the X-rays start to fan out from the source. It hits the patient, and then you have a detector over here. So the typical position is for the patient's back to be facing the X-ray source. And because their back is facing the X-ray source, this is called posterior anterior, i.e. PA chest X-ray. And this is just a schematic of that. So remember, the heart lies in the anterior part of the body. So if you have an X-ray source here and a detector there, and a patient is in the PA position, you'll get a fairly accurate representation of the heart size. However, if the patient's front is facing the X-ray source, i.e. this is an AP, an anterior posterior X-ray, where the patient's front is facing the X-ray source, remember the heart lies at the front of the body, so that gives more distance for these X-ray beams to fan out, and therefore the heart looks bigger, a lot bigger than what it actually is. So the fact that if you do an AP chest X-ray, the apparent size of the heart appears a lot bigger than it actually is, means you can't properly assess heart size on an AP chest X-ray. Whereas on a PA, you get a much better representation. As you can see, this gray arrow is the apparent size of the heart that will appear on the chest X-ray. So although it's a little bit bigger, it's only marginal, whereas on an AP chest X-ray, you can see that's huge. So that's why we cannot use AP chest X-rays to assess heart size in general. So this is the way we acquire a chest X-ray. We fire an X-ray beam at the patient with a detector behind or in front of the patient. So why don't we just always use PA chest X-rays? Why do we bother with APs? When do we use an AP chest X-ray? So yeah, if the patient is too unwell, you do an AP chest X-ray. Because with a PA chest X-ray, the patient is standing up, okay? So that the patient has to be well enough to stand up for a PA chest X-ray. If the patient is really unwell and they can't stand up, you often lie them down. You can have them sitting down, but you can lie them down, and that's called a supine AP chest X-ray. Supine just means lying down, because obviously if the patient is too unwell to stand, you have to lie them down. If you have to lie them down, you're going to lie them on their back. You can't really lie an unwell patient face, with their face planted into the mattress. So you lie them on their back, and then you put the X-ray source above them and do an AP view. So how are we going to approach chest X-ray? The first thing is how to acquire the chest X-ray, which we've covered. Whenever you're presenting an X-ray for finals or as a doctor, you always start off with the patient details and projection. So this is Mr. X, and this is an AP or a PA chest X-ray. You then look at the technical factors, so rotation, inspiration, exposure or penetration. Then after you've done that, the first thing you always look at are lines and metalwork. After you've done all of that, only then do you actually start to tackle the rest of the chest X-ray. So airway is the trachea, breathing is the lungs, circulation is the heart and the mediastinum, diaphragm, and E for everything else. So that's everything else that you haven't looked at, including your review areas. So the reason we make a big deal about review areas is because these are the areas that are often missed out on an X-ray. So your lung apices, your costophrenic angles, behind the heart, around the diaphragm, and make sure to pay attention to the soft tissues and bones, because it's common for fractures to be missed on a chest X-ray because people don't look at the shoulders and the clavicles. So this is your approach to assessing a chest X-ray. For every X-ray, every chest X-ray that you look at, follow this approach and you won't miss anything. Even if you don't know particularly what the abnormality is, at least you'll be looking at the abnormality and be able to pick it up. Even if you can't really describe it, that's not a problem. So how do we assess rotation? So this is a technical factor. What that means is if any of these factors are off, then it means we can't properly assess the chest X-ray. So if the patient is rotated, if the inspiration is incorrect, or if the exposure is incorrect, it's hard to properly or harder to properly assess the chest X-ray. So how do we assess if the patient is rotated? Good, clavicles, very good. So I kind of done a bit of a rubbish drawing here, but these are the medial heads of the clavicles. And what lies in the middle of those are these spinous processes here. So the spinous processes should lie completely in the middle of this distance between the clavicular heads, okay? So the spinous processes must lie in the middle of the clavicular heads. And if it doesn't, if they don't, then that means the patient is rotated, i.e. they're not completely front on, their shoulders are slightly rotated to one direction. And that changes the orientation of the chest X-ray and makes it more difficult to assess. I know this might be a bit basic for some of you, but don't worry, it will get harder after this. So that's rotation. And the reason is you need to know these technical factors for your exams because sometimes they ask you. Inspiration looks at the number of ribs. So how many ribs should we have anteriorly on a chest X-ray for adequate inspiration? Good, 5 to 7. So you've all got that right. And how many posteriorly? Roughly. Yeah, so 10. So if you look here, we've got 1, 2, 3, 4, 5, 6 anterior ribs. You've got a 7th one here, but that's basically the way you assess it is which rib intersects the hemidiaphragm at the mid-clavicular line. So it's the 6th rib which intersects the diaphragm at the mid-clavicular line. So we've got 6 anterior ribs. And how many posterior ribs? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So this is an appropriately inspired film. The inspiration on this is perfect. Okay, so 5 to 7 anteriorly and about 10 posteriorly. That is what we want for adequate inspiration. And exposure. How do we assess exposure? What are we looking for? What even is exposure? So you're looking at the vertebra behind the heart. So if you can just about see the vertebra, and more specifically, if you can just about see the intervertebral disc, so the black space between the vertebra, then that is adequate exposure. And you might be thinking, what is exposure? So exposure is basically, do we have enough X-ray beams passing through the patient to give us an adequate image? That's all exposure is. And if some of you do photography, you might understand that a bit better, as I will show you on the next slide. But adequate exposure means you want to just about see the vertebra behind the heart, and more specifically, the intervertebral disc space. So these are the technical factors. As radiologists, you don't comment on the technical factors unless there's an issue. So for every film that I report, I'm not going to go through these things unless there's an abnormality, then I'll mention it. For your exams, you should always mention it. And if it's normal, just say the film has adequate, the film is adequate. If there is an issue with rotation, inspiration, or exposure, then mention it. Say the film is inappropriately rotated, there is poor inspiration, there is poor exposure, etc. Okay, so always make sure you comment on the technical factor in your OSCEs and in your exams. Okay, so this is an example, and for those of you who do a bit of photography, you'll probably understand this a lot better than I do, but this is normal, this is overexposed, and this is underexposed. So it's all to do with the amount of X-rays, or in this case, light that is passing through the camera lens and being picked up, okay? If you overexpose and let too much light get through, your image appears too bright and you can't really distinguish different features from each other. If you have too little light going through the camera lens, then it appears dark, and again, you can't properly distinguish the finer details. But the middle one is just perfect. And that's the idea of exposure. Technical factors done. Okay, forget the problem in the lungs, ignore the lungs. What is the technical inadequacy on this film? So someone said exposure, but I think I can just about see vertebra behind the heart, so exposure is good. Maybe it's not projecting well on your screens, but I can just about see the vertebra behind the heart. So rotation, if we look at the clavicular heads, so those are the clavicular heads there. And where is the spinous process? It's here. So does that line the midline? Well, no, it doesn't lie in the midline. It lies well off to the left side. So this is a rotated film, and it's probably got poor inspiration as well. I haven't actually counted the ribs, but it just looks like the lung fill. If we do that, 1, 2, 3, 4, 5. So the inspiration is actually not bad. It's got 6 ribs anteriorly, but this is a rotated film. So the patient is rotated to one side. It doesn't really matter which direction they're rotated in. It's just the fact that they are rotated means you can't properly assess the film. So in your exam, you'll say this film is rotated, okay, when you start off presenting. This is an AP chest X-ray of Mr. X. It's a rotated film, and then you'll carry on in your presentation. Okay. Again, what's the issue here? What is the technical inadequacy here? So someone's asked, what if the patient can't take a deep breath in? Then obviously you just have to make do with what they can. If they can't take a deep breath in, then you'll just have a poor chest X-ray, but you can still interpret it. Yeah, so it's there's poor inspiratory effort, I would say. I haven't counted the ribs, but maybe the lung spaces look a bit small, but it's rotated again, okay? You can see the patient's bent to one side. And again, here's the spinous process. Here's the clavicular head. Here's the other clavicular head. So this is a rotated film. Also, I would say that the penetration probably isn't the best. I can't really, maybe just about, so I can see a vertebra behind the heart, but very, very difficult. So this is rotated and poor penetration, okay? Fine. So we've done technical factors, and hopefully you guys are happy with that. If you have any questions, just drop it in the Q&A and I will get to that. Patient details, we always start off with technical factors. whenever you're looking at a chest X-ray, the first thing you do is you look for lines and metalwork before you even get on to looking at the lungs. Okay, so look for lines and metalwork. Then you attack the lungs, A, B, C, D, E, so trachea, breathing is the lungs, circulation is the heart, and the hilar. So the hilar are these prominent bits just to the side of the heart. Then you look at the diaphragm, and then everything else that you haven't looked at, including the review areas that I mentioned. And we're gonna have examples where we actually work through things in this order, so don't worry if this is all new to you. Just some very basic anatomy. We'll go into more in-depth anatomy with some of the cases, but we have the trachea. The carina is where the trachea splits into the right and left main bronchus. So I'm sure you guys all know this, but on a chest X-ray, this is the right side and this is the left side. Remember, these prominent bits are the hilar. So they have the right hilum and the left hilum, and they contain the pulmonary vasculature. So the pulmonary arteries and veins. That's what gives this shadow, and some lymph nodes as well. You have the right hemidiaphragm and the left hemidiaphragm. These sharp bits here are called the costophrenic angles. And then we have the gastric bubble. So don't get confused. This isn't pneumoperitoneum. This is the stomach. This is air within the stomach. You can see it's well contained. It's very circular. This is called the gastric bubble. Very basic anatomy, hopefully. Okay, so we'll go through some cases. The first thing I want you to get in the habit of is thinking, is this film normal or abnormal before you do anything? Okay, before you even start looking for the abnormal, well, trying to characterize the abnormality, is it normal or abnormal? Then you can think about the anatomy and the pathology. You know, is this in the upper lobe? Is this in the lower lobe? Is this collapse? Is this consolidation? So all that stuff comes later. First of all, get used to looking at normal films. Because if you don't know what normal is, you can't know what an abnormal film is. So let's have some practice. I don't want you to tell me the abnormality or any specifics. Just say, is this normal or abnormal in the chat? Okay, we have a mix. So this is what I mean. You need to get used to looking at normal films. So this is actually normal. This is a normal film. So the trachea is nice and, you know, it's well positioned. The heart's absolutely fine. There's nothing in the lung fields. The diaphragms are appropriately positioned. If you're looking around the actual film itself, there's no issues. So some of you, I think maybe this is why you thought it was abnormal because of this. That's normal. Okay, that's why you need to look at a lot of normal films. That's just the pulmonary artery there, and it can be a bit dense in some people. That's absolutely fine. That is just part of the pulmonary vasculature, and as I said, that's part of the hilum. Nothing to worry about there. Okay, normal or abnormal? So remember, chest x-rays are really difficult. So don't worry if you're struggling. Like, x-rays are the most difficult imaging modality to interpret. So this is normal, okay? I mean, you could argue there's one slight abnormality in this film, and that the sharp-eyed amongst you might have noticed there's a PICC line. There's a PICC line running into the heart over here. Very subtle. But otherwise, actually, the lungs themselves and the rest of the x-ray is completely normal. Maybe some of you guys thought this stuff down here was a bit abnormal. That's absolutely fine and within normal limits. You just need to get yourself into the habit of looking at a lot of normal films. Somebody said the cardiothoracic ratio looks large. I wouldn't say so. That looks about half of the thorax, and we'll come on to that later. So this is a normal film. The mediastinum is not widened. That's the aortic knuckle. That's the aortic arch, okay? The aortic arch forms a knuckle on the chest X-ray, which looks like this, and that's completely normal. So don't worry if you struggled with that one. Okay, thoughts, normal or abnormal? Okay, so we've got a suggestion for hyperinflation, but if we look at the number of ribs, 1, 2, 3, 4, 5, 6. 5 to 7 is normal, so I wouldn't say this is hyperinflated. Good, this is a normal film. Again, trachea is normal, lungs are normal, heart is normal, looking around the heart, the hilar are fine, diaphragm is fine. So remember, following the ABCD approach, looking in our review area, so behind the heart, behind the diaphragm, in the apices, around in the soft tissue and bones, that's a completely normal film. Okay, thoughts, normal or abnormal? Good. See, now you've seen a normal. This is normal. This just looks weird. Like, what's going on down here? That's why always look. Yeah, the exposure is not great, which is why it looks kind of whited out. The actual lungs are normal. Okay, the lungs in this film are normal, but as we'll come on to later, I'll explain the abnormality at the end. I think a few of you picked it up already, so well done. But compare this film. So this is why it's really important to look at hundreds of normal films. Just spend an hour looking at a bunch of normal chest X-rays. So I agree. This is a much better penetrated film, which is why the lungs appear nice and black and quite crisp. The penetration here isn't great, which is why it looks very whited out. But that's actually, there's no focal problem in the lungs. The problem is actually beneath the diaphragm. So there's air here. Okay, that's not normal. That's why one of the review areas is always below and behind the diaphragm, because if you miss this, that's a serious problem. The patient may die. We'll come on to that later. Okay, normal or abnormal? I'm just looking at this myself to make sure I haven't made any stupid errors, but yeah, this is normal. Okay, this is a normal film. Again, ABCDE approach, airway is fine. Lungs are fine. There's no focal lesions. There's no collapse. There's no like big white lesions. The heart looks nice and crisp. I can see the borders very nicely. Okay, so this is the way you assess the heart. You trace around it and you should be able to see the borders very nicely. Again, the borders of the diaphragm, nice and crisp. Looking around the X-ray, that's all perfectly fine. And again, don't be put off by these prominent blood vessels in the hilar. They are normal. Okay, that's absolutely normal. And yes, it is a female patient because you can see breast tissue. So again, don't think, sometimes people think that's a pneumothorax, that's just breast tissue. Anything else on this X-ray that I want to talk about? Yeah, so just remember, look at the crisp heart borders, look at the crisp hemidiaphragms. If you ever lose one of those borders, that is an indication that something has gone wrong. So look at those borders very carefully. Normal or abnormal? Good. So now I hope you can see getting into the habit of looking at normal films helps you pick out what's abnormal. This is an abnormal film, and we'll come on to this later as to why it's abnormal. I'm not going to go into the pathology now. At the end, at the end of the lecture, I'm going to go through all of these abnormal films I've mentioned here, and we will go into the exact abnormalities. But this is abnormal. If you compare that to that, something that just looks a bit odd on this chest X-ray. Okay, normal or abnormal? Good, normal. Again, airway is fine. The lungs, no focal lesions. Looking at the heart, nice crisp borders. Looking at the diaphragm, nice crisp borders. Looking around the X-ray for everything else, nothing obvious. Again, some of you might be put off by this prominence in the right hilum. I'm sure we've seen quite a few of these now, and that's absolutely fine. That's just prominent. That's just prominent pulmonary vasculature. Nothing to be concerned by. Okay, normal or abnormal? Good, abnormal. So airway looks fine. The lungs, there's something a bit odd here. Okay, we've lost the right hemidiaphragm. It's blunted, isn't it? There's something a bit odd going on over here as well, in the lungs, sorry. So there's something strange going on here. The diaphragm doesn't look quite right. This is an abnormal film. So compare it to the previous normal. Nice crisp hemidiaphragms, nice crisp heart border. We've lost that nice curved hemidiaphragm on the right. And the heart border just looks a bit odd, doesn't it? So there's something wrong with this film. Someone said the aortic knuckle looks prominent. That's just normal, okay? Normal or abnormal? Yeah, that's right, Mohammed. The previous film was rotated as well. Abnormal, very good. I'm glad you all got this. So the airway is fine. So remember, before we look at the airway, we look at lines. There's a line, firstly, going into the right atrium. We'll go over the anatomy later of lines. The airway looks fine. I can't see any focal lesions in the lungs, but when we get to the heart, we've lost the inferior borders of the heart. Okay, we can't quite make out that right heart border or that left apical border. And we've lost that nice rounded contour of the hemidiaphragms. There's blunting of the costophrenic angles on both sides. So there's a problem on both sides of the lungs. So again, if we go back to normal, you should have these nice rounded contours, nice sharp costophrenic angles. But here we've lost the costophrenic angles and we don't have that nice curved hemidiaphragm. Again, I'll go into the pathology later. Don't worry about the clavicles. There's probably just the patients like leaning forward or something. Yeah, they do look quite low there, but that's fine. Okay, I think we've done enough of this. This is normal again. Don't be put off by the prominent right hilum. Nice crisp hemidiaphragms, nice crisp heart border, nothing going on around the actual chest X-ray. Fine, let's crack into some proper case-based learning now. Which of the following indicates a malpositioned NG tube? I think there are a few questions, so I will try and get to them. To answer that on Menti. Okay, just looking for your question. Someone's asked, what does overexposed chest X-ray look like? The lung fields will look black. The lung fields will look very dark and black. And if it's underexposed, the lung fields will look white. Okay, difficult question, but bisects the right main bronchus is the correct answer. So tip under the left hemidiaphragm is right because that's where the stomach lies. The stomach lies under the left hemidiaphragm, so that's correct. It should bisect either the carina or the left main bronchus. It should, of course, follow a midline course. If you see it veering off completely in one direction, that suggests it's in the lung. And it should be 10 centimeters distal to the gastroesophageal junction. The tip should be distal. it shouldn't bisect the right main bronchus. That suggests that it's taken an inappropriate course. So NG tubes, for those of you who don't know, they go in through the nose and they end up in the stomach and they're used for feeding. If you position the NG tube correctly and you feed the patient will die because all the feed will end up in the lungs. And that happens occasionally every year in hospitals, and it's called a never event. That should never happen. So is this NG tube appropriately positioned or not? Good, so it is appropriately positioned. If we follow, so these are some lines that you might be expected to know about. Following our methodical approach, always look at lines and metalwork first. The NG tube is safe. The rest of the A, B, C, D, E part of the X-ray looks normal. The review areas look normal. So how do we actually assess NG tube position? Is it in the midline, step one? So this, you can see it's pretty much in the midline of this chest X-ray. Does it cross the carina or the left main bronchus? So it crosses the left main bronchus there. Might be a bit difficult to see on your screen, but the bronchus. So it crosses the left main bronchus, so that's perfect. Does the tip lie below the left hemidiaphragm? This is the left hemidiaphragm here, and the tip is just cut off on this chest X-ray, but it does lie below the left hemidiaphragm. And the final thing is, does the tip lie 10 centimeters distal to the gastroesophageal junction? So the gastroesophageal junction is the point where the esophagus meets the diaphragm, so it's somewhere here. Again, we can't properly assess the measurement on this chest X-ray because we can't see the tip, but all other factors considered, this is an appropriately positioned NG tube. Okay, what about this NG tube? Where is it? So it's in the left main bronchus. It's gone down the left main bronchus and ended up in the lung. So it's come down the trachea. Instead of going into the esophagus, the NG tube has come into the trachea and it's popped off down the left main bronchus and into the lung. So if you feed this patient, they will aspirate and they will most likely die, okay, from that feed, because they'll just fill up their lungs with feed and they'll start choking and aspirating from all of that. And then look at the rest of the A, B, C, D, E of the X-ray. What do you think, normal or abnormal? Why is it abnormal, other than the NG tube? So someone's asked a good question. You always aspirate the NG tube first, but if you can't aspirate it, or the pH that you're getting back is a bit alkaline, then you do a chest X-ray to check the position. Good. Brilliant. The right costophrenic angle is blunted. There's a pleural effusion there. Okay. That's the ABCDE abnormality. Someone asked what this line is. That's probably the NG tube on the outside as it's going into the patient, because it a bit of it just dangles on the outside of the patient. Sorry, I said ABCDE here is normal. It's not. There's a left-sided pleural effusion. Okay. Endotracheal tube, that's used to intubate and ventilate patients, and it should be 5 ± 2 centimeters above the carina. So I got asked this sort of stuff in my exam, which is why I am in my finals exam, which is why I've made a point to teach it. So this is the endotracheal tube here. Hopefully you can make that out. It's this tube here, and that, if you look at the tip of the endotracheal tube, the distance between the tip and the carina should be 5 ± 2 centimeters. If it's too low or too high, it needs to be repositioned. And sometimes what can happen is that the endotracheal tube can go down into one of the bronchi, which means you only ventilate one lung. So if you only ventilate one lung, what's going to happen to the other lung? So this is a big problem. Yeah, it's going to collapse, and that sometimes happens. The anesthetist will intubate one bronchus, the other lung won't get ventilated, and it will collapse, and the patient will go into respiratory failure. So that's not good. Yeah, that's right. The carina is at T4 or T5, and the carina is the bifurcation of the trachea into the left and right main bronchus. An ET tube is an endotracheal tube, which is used to ventilate patients. So you connect it to a ventilator on ITU, and it will ventilate the patients. And these are ECG leads, okay? Otherwise, it's a normal chest X-ray. So the cases I've shown you are the cases you'll get in exam, but these are the sort of cases you get in real life, and it's an absolute nightmare. So someone said abnormal, definitely abnormal. So starting off with lines and metalwork, what lines and metalwork can you see? Okay, let's take them one by one. So yes, sternotomy wires. So that's these circular things here. The patient has had a midline sternotomy. What operation have they had? Why have they had a midline sternotomy? CABG is possible, but I don't think so, looking at this chest X-ray. I don't think it's a bypass or a CABG, same thing. What else can you see on the chest X-ray? Good, you can see a metallic heart valve, okay? So this patient has probably had open heart surgery to put in this heart valve. So it's quite fun looking at X-rays because you can sort of piece together the puzzle. They've had a valve replacement through a midline sternotomy. What else? What other wires? What are these wires here? These little clips on the shoulders. So these are ECG leads, okay, or cardiac monitoring leads. So these can be like 3-lead ECG. Other lines, they've got an NG tube in running down the midline. They have another line here going into the superior vena cava. So it's coming in through the internal jugular vein. So that looks like a central line, okay? Got a line there and then neck. What other line do they have? So remember, look at the review areas. This is why looking at the review areas is very important. I don't think they have a PIC line unless, no, I wouldn't say they have a PIC line. So if we look, if you turn your attention, what's this here? They have an abdominal drain, okay? They've got a line going into the abdomen below the diaphragm. So something's draining down there. So this patient's obviously seriously unwell, and we've missed the massive elephant in the room. What's this thing here, this massive piece of metal? So that's a spinal fixation device. The patient has had spinal surgery, and probably orthopedic surgeons have put a big metal rod in their spine to hold, like to try and correct the position or something like that. So it's a spinal fixation device. So got ECG leads or cardiac monitoring leads. Endotracheal tube as well here. Okay, there's an endotracheal tube going down there, terminating here. There's an NG tube which runs all the way down into the stomach. There's a central line. There's an abdominal drain. There's spinal fixation. There's midline sternotomy wires, and there's a metallic heart valve. A, B, C, D, E, we've got a left-sided effusion because we've got blunting of that left costophrenic angle. So my point is that you'll never get something this difficult in your exam, but when you are all doctors or physicians associates one day on the ward, these are the sort of cases you'll be looking at, and you may find it difficult, but don't worry, use the systematic approach. and you will nail everything. Okay, let's crack on. So what's the diagnosis? Good, pleural effusion. I've gone on about effusions, but I haven't really actually talked about what they are. So we've done lines. I haven't really talked about PICC lines, but you can, there's not enough time, so you guys can look that up. Pleural effusion is a collection of fluid in the pleural space. It's as simple as that. How do we know a patient has a pleural effusion? Well, this is the amazing thing about chest x-rays, is that you can compare one side to the other. Nice, sharp costophrenic angle, nice, sharp hemidiaphragm, nice, sharp heart border. Look at this side, lost the heart border, lost the hemidiaphragm, no sharp costophrenic angle, and we've got a meniscus. It's this like circular, semicircular appearance. That is classic for a pleural effusion. Okay, this semicircular meniscus. So this patient has quite a large pleural effusion. Systematic approach, no lines or metalwork, unilateral left-sided pleural effusion. The review areas are normal. Someone said, is it hyperinflated? It might be. Let's see. 1, 2, 3, 4, 5, 6 ribs. No, don't be confused. If the image is elongated, that's not the same as hyperinflation. The patient could be really tall. We see 6 ribs there. That's not hyperinflated. Always compare a normal chest X-ray to an abnormal chest X-ray when you're starting out. Look at tons of normals, and then you'll be able to figure out what the abnormal is. Obviously, this is clearly abnormal. But it really helps you identify the differences. And just as a point here, I think a lot of you might get confused as what's consolidation, what's effusion, what's collapse. Anything white on a chest X-ray is either going to be an effusion, collapse, consolidation, or a mass. If you see something white on a chest X-ray, that's not supposed to be there. It's either an effusion, consolidation, collapse, or a mass. Okay, so just 4 things. So if we look at this, this is white. It's got a meniscus. You've lost the hemidiaphragm and the costophrenic angle. It's therefore an effusion. So this is a bit of, I guess, more pathology for you. Which of the following suggests an exudative pleural effusion? So this is something you need to know for your exams, mainly for your SBAs. They won't really ask this in OSCEs. I'm just looking at some of the questions on the Q&A, and someone's asked, why put an NG tube in for a pleural effusion? They're talking about the case a few X-rays ago. The NG tube wasn't put in for the pleural effusion. They just happened to have a pleural effusion and an NG tube in. They're two separate things. What's a PICC line? A PICC line goes in through the arm, in one of the arm veins. A central line goes in through one of the neck veins. Would effusions look different if a patient was supine? Potentially might be a bit more difficult to see if it's small, but if it's large, you'll still see that meniscus and the loss of the hemidiaphragm, etc. Okay. So this requires you to know Light's criteria, which I can never really remember, but yeah, that's the correct answer. Obviously, I had the benefit of looking this up and making the question, but sadly, you guys need to learn Light's criteria, which isn't the most fun thing, but there you go. Again, like it's just something you need to learn. An exudate has usually greater than 30 grams per liter. Some people say greater than 25 grams per liter. Light's criteria says pleural to serum protein ratio of greater than 0.5, pleural to serum LDH ratio of greater than 0.6, or a pleural LDH of greater than 2/3 the upper limit of serum LDH. So that's why this is incorrect. You're looking at the pleural LDH, not the serum LDH. Yeah, and the protein should be greater than 13. So what is a pleural effusion? It's all it is it's a collection of liquid between the parietal and the visceral pleura, between the two layers of pleura. And this is important to know. So how do we split up pleural effusions? You can either split them up into unilateral and bilateral. Unilateral effusions are concerning, particularly if the patient is elderly. An elderly patient with a unilateral effusion, think cancer. It could be infection, it could be bleeding, or it could be lymph as well. But if it's a smoker, an elderly patient with a unilateral pleural effusion, think cancer. If it's on both sides, then you're thinking of fluid overload. So do they have heart failure, renal failure, liver failure? Have you given them too much fluids? You know, have you, through a cannula, have you given them too much fluids and that's caused them to be fluid overloaded? So think of these things. The other way you can classify is an exudate versus transudate. And the way you do that is either looking at the protein or looking at Light's criteria. And again, those are your various causes. But I'm not really going to touch on that right now because I want to focus on imaging. But the slides will be there for your reference. Okay, what is the diagnosis? The image will come up. Do not worry. Oh, this, yeah, it's probably not the best chest X-ray. It's a bit unfair. Yeah, central line goes into the internal jugular vein. That's correct. Could the previous X-ray be a hemothorax? It could be, yeah. So a pleural effusion encompasses all of those things: blood, liquid, lymph, etc. But it's just hemothoraxes and chylothoraxes obviously slightly less common. And if the patient hasn't had a history of trauma or bleeding, you wouldn't really suspect it. Okay, I think this was a bit unfair of me actually, now that I look at the answers. But the answer is actually pneumonectomy. Why does anyone know why it's a pneumonectomy over a right lung collapse? I'll be very impressed. Or maybe it was just a guess. Okay, interesting. I'll show you why. So if we zoom into this, what do you notice? So this could be collapse or a pneumonectomy, but what do you notice? That's there, that shouldn't be. What do we always look for before? Yeah, so you've nailed it. You see clips. You always look for lines and metalwork, etc., before looking at the lungs. I don't know if you could see that properly, to be fair, on your question, so it was a bit unfair, but there are surgical clips there. So this is the sort of stuff you know that would be quite cool to pick up. But yeah, I mean, if you said lung collapse, that's also a very reasonable differential. But the fact that they have a whiteout with surgical clips, that suggests they've had a surgery to their chest, probably a pneumonectomy. Saying collapse isn't entirely wrong. It's a very plausible differential. So I want to go over loss of lung volume. So hopefully we won't be more than sort of 20 minutes or so. I still think I've got a bit to get through. But loss of lung volume is either a collapse or a pneumonectomy or a lobectomy. They'll all look the same. Okay, you can't really tell a collapse from a pneumonectomy from a lobectomy unless you've got something like surgical clips to suggest they've had surgery. The cardinal features are you have opacity. Okay, in radiology we call white stuff on X-rays opacities. So you have this opacification. Whenever you lose lung volume, the trachea shifts in the direction of the lung that's been of the volume loss. So if you've lost volume on the right, the trachea will shift to the right. That is a sign of loss of lung volume. If you've lost lung volume, the hemidiaphragm will be raised as well on that side. You can't see it here because there's a complete whiteout on the right side. But if you lose volume, your trachea shifts and your hemidiaphragm shifts, and you get an opacity. Three things. So loss of lung volume, you get an opacity, tracheal shift, and hemidiaphragm shift. That's the cardinal features of loss of lung volume. That can either be a collapse, a pneumonectomy, or a lobectomy. Taking it one step back, if you see any opacity on a chest X-ray, think collapse, think consolidation, think effusion, think mass. In this case, we're talking about pneumonectomies and collapse, etc. So the fact that they've lost the entire right lung, it's all white, is because the lung has been taken out and this space has become filled with fluid, and the fluid appears dense and opaque on the chest X-ray. So this is a pneumonectomy. Again, this is how you describe it. A pacification of the entire right hemithorax with surgical clips suggests the patient has had a right pneumonectomy. You can't really see the right bronchus too well. It might be there. It might be obscured by the overlying fluid, or maybe part of it was taken out. Okay. Someone's asking, what's the dark tube at the top? So this is the trachea, if that's what you're talking about. I can't see any other tubes, but we can come back to that later at the end. What's the diagnosis here? Okay, so this is not normal, is it? Normally the heart should be nice and rounded, but there's something overlying the heart that looks very weird. It's like a triangle shape. You have a well-defined, dense, triangular opacity in the right lower zone, and you've got obscuration of the right heart border, and we've also lost the medial part of the right hemidiaphragm. Remember, normally that right hemidiaphragm should be nice and crisp, but we've lost the middle part. And if you look at the trachea is slightly ever so shifted to the right. So this is volume lost. The patient has lost some lung volume. I agree the hemidiaphragm isn't particularly raised, but that's only because it's not a major collapse. So this is a right lower lobe collapse. This is how it typically appears. And someone has asked an excellent question. So how would consolidation differ from this? Any thoughts? How would consolidation differ from collapse? Because I told you an opacity on chest X-ray can either be collapse, consolidation, effusion, or a mass. So good. The borders, look at the borders, really well defined. If you have an infection or an area of consolidation, it's not going to appear so well defined. The other thing is the density. This is really dense. We have an example of consolidation at the end. Consolidation is a lot less dense. So number one, this is really well defined. Number two, this is dense. And number three, in consolidation, you have air bronchograms. And quite correct, someone said the trachea shouldn't move if you have consolidation. So this is more in keeping with collapse. You need to put everything together. But the classic features that differentiate this from consolidation, well-defined, very dense, and no air bronchograms. I'll show you what air bronchograms are later. Good. And again, let's always compare normal to abnormal. So remember, nice sharp heart border here, nice sharp hemidiaphragm. Weird triangular opacity here, lost the heart border, lost the medial right hemidiaphragm. Something weird is going on in the right lower zone. This is right lower lobe collapse. So someone's asked, yeah, so you've just in the chat responding to that question, we've lost the right heart border. So if you compare the two, nice sharp right heart border here, you can't really make out a sharp right heart border here. Remember, right lung, left lung, upper lobe, middle lobe, lower lobe. Left lung only has two lobes, the upper lobe and the lower lobe. And then you have the horizontal fissure and the oblique fissure of the right lung. The left lung only has this oblique fissure. Again, some basic anatomy. What's the diagnosis? Ignore these metal things. I don't really, maybe they're surgical clips or something. What's the abnormality? Ignore the heart as well. This is a baby, so the heart, yeah, there is cardiomegaly, but what's the lung abnormality here? Good, right upper lobe collapse. Okay, this isn't consolidation. Remember, look how well defined it is. It's nice, almost got this very well curved, well demarcated border. It's dense, it's very homogeneous. There's no air bronchograms. This is collapse. Okay, and this is an endotracheal tube here. This is a neonate, by the way. That's why the X-ray looks a bit weird. Endotracheal tube. Weird opacity in the right upper zone, dense, well demarcated, homogeneous. This is right upper lobe collapse, and there is an ET tube. So causes of lobar collapse, you can think of luminal, mural, or extrinsic. So luminal means within the airway. You can have a foreign body, particularly common in children who aspirate, they swallow coins and things like that, or the elderly who have poor swallow mechanisms and they're at risk of aspirating. Mucus plugging, so in an infection, mucus can plug the airways and that can lead to collapse. Or an obstruction within the airway, like a malignancy. Mural means within the wall of the airway. So again, that's a malignancy, can grow in the wall and then obstruct the airway. Or if you have extrinsic compression of the airway, again, think malignancy. So someone just asked about the hemidiaphragm being raised. The hemidiaphragm doesn't always go up. That's just a classic feature. So the hemidiaphragm here is pretty normal. But you can see here that this looks like classic collapse because of those features that I described. And again, maybe the trachea is slightly shifted to the right, because if you look at this ET tube, it lies slightly right of the midline. But I agree, the right hemidiaphragm is not raised. Okay, abnormality, tell me. Something does not look right here. So what do we think of this heart? Is that normal? So the heart is absolutely huge. It's cardiomegaly. Some of you are saying widen mediastinum, etc. True, but why is the mediastinum widened? It's because the heart is absolutely massive. So the specific diagnosis is cardiomegaly. So if we're talking about heart failure and pulmonary edema now, the way you check for cardiomegaly is you measure the width of the thorax. So you measure this width here, and you measure the width of the heart. And if that ratio is greater than 0.5, the patient, or 0.55, depending on what source you read, the patient is said to have cardiomegaly. So this patient has a massive heart. So I actually saw this chest X-ray yesterday. A friend showed it to me. And most of these chest X-rays are actually from my practice, and I've just kind of copied them into PowerPoint. But this one is a 48-year-old. Okay, so it's a young lady, and she's got tricuspid regurgitation. So that's why her heart is absolutely huge. She's probably had tricuspid regurgitation from a very young age, and that's led to significant heart failure and enlargement of the heart. You can't actually, some of you can't actually tell, it's very difficult to say what's caused the cardiomegaly on a chest X-ray. You need a bit of history, okay? Again, looking at the normal heart, look how nice and crisp and small that is, and compare that to this massive globular heart. So this is cardiomegaly here. Some heart anatomy for you. This is the superior vena cava. What heart border is this here? So that's right atrium. Okay, that's the right atrium. What heart border is down here? Sorry, what heart chamber? This is the right atrium. What heart chamber is down here? The right ventricle. What heart border is up here? Left atrium. And what, therefore, this must be the left ventricle. Okay, so right atrium, right ventricle, left ventricle. It's a bit weirdly orientated in the thorax. That's why it's kind of like the heart's kind of rotated in the chest. That's the aortic arch, and it comes around to give you the aortic knuckle there on the chest x-ray. So the aorta comes out of the left ventricle, wraps round and passes posteriorly down the thorax as the descending aorta. Some basic anatomy. I'm not going to go through this. It's on the slides. It's far too detailed for my liking, but you guys can go through that if you wish. Okay, aiming to finish in 10 minutes. So I'm going to try and, whatever we don't finish today, we'll go through in the next session, so don't worry. What's the diagnosis? Give me one unifying diagnosis here. So yeah, pulmonary edema, a heart failure likely causing pulmonary edema. How do we assess for pulmonary edema? Well, you look for the A, B, C, D, E signs. Alveolar edema means fluid in the alveoli, and how does that look like? Well, you can see the hilum here is really, really prominent. Okay, I know we've seen some prominent hilum before, but this is really dense and fluffy. It should not look like that, and that's called alveolar edema. That's fluid collecting within the alveoli, and it appears like that, and it's sometimes called a bat wings appearance. Yeah, exactly. Someone said it in the chat. This is a bat wings appearance, and that's called alveolar edema. Curly B lines, I mean, I'll show you that on another chest x-ray. Cardiomegaly, so the heart should be enlarged, but remember this is AP, so difficult to assess. But just grossly speaking, you can kind of get an idea that the heart does look quite big, does look quite large, but again, you need a PA to properly assess that. Dilated upper lobe blood vessels. So if you look in the upper lobes, you can see a lot of, you can see these, just get my laser pointer out. Bit difficult to appreciate here, but you can see a lot of lines pointing upwards, and that's prominent upper lobe vessels, which suggests, again, pulmonary edema. And finally, pleural effusion. So this patient's got a bilateral pleural effusion, blunting of the costophrenic angles bilaterally, loss of that nice curved appearance of the hemidiaphragm. That's classic pleural effusion. So this is pulmonary edema. And the reason I think this is due to heart failure is because even though it's an AP film, the heart looks quite big. Okay, so they've probably got some heart problem, which is causing the pulmonary edema. Look at the normal film, look at the abnormal film. Really dense, fluffy hilar. Some prominence, but not as dense and fluffy on the normal film. So that's alveolar edema. And then look at the pleural effusion. Nice sharp costophrenic angles here, not present here. The heart looks a bit big, but again, it's an AP film, so you can't really say. But it's just important. Compare left to right, and you can really see there is a big difference. So hopefully I can convince you of what septal lines are, or curly B lines. We couldn't really see them on the previous chest x-ray. This is a different chest x-ray with pulmonary edema. And if I zoom in to this section on the right lower zone, hopefully you can see some horizontal lines. And those are known as curly B lines. So they're very faint, but if there's one there, there's one there, there's a few here. Okay, they're very faint horizontal lines in the peripheries, and they are evidence of fluid collecting in the interstitium. So that's interstitial fluid. Whereas the bat wing's appearance is fluid in the alveoli. So fluid in the alveoli, fluid in the interstitium. And these are curly B lines. Okay, diagnosis. It's a bit difficult to see, but you should be able to pick it up, I hope. Very good. So pneumothorax. So next thing we're going to move on to is pneumothorax. You can see a pleural edge here. Lung is collapsed. So the way you assess for a pneumothorax is you look for a pleural edge and you look for lung markings. So if you look in this region, distal to the pleural edge, there are no lung markings. Whereas if you look in the periphery of this lung here, the lung markings extend all the way to the periphery. Whereas this looks black, you can't see any lung markings and you can see a pleural edge. So this is a pneumothorax. The other thing you want to look for is tracheal shift or mediastinal shift, because if there is significant mediastinal shift, that suggests the patient has a tension pneumothorax. So loss of lung markings and visible pleural edge suggest a left pneumothorax. Always go through your systematic approach when presenting, but I'm just focusing on the key findings here. What is a pneumothorax? It's just a collection of air in the pleural space. So a pleural effusion was a collection of fluid. A pneumothorax is a collection of air. And sometimes when that air, when the pressure builds up and you get mediastinal shift and compression of the heart, that's called a tension pneumothorax. So I'll probably skip this question, but the slides will be available and you can look it up. But where do we measure a pneumothorax from? The hilum or the apices? Good, that's what I was trying to get across in this question here. So although the pneumothorax is 3 centimeters at the apex, it's only 1 centimeter at the hilum. And this is the measurement that we go on, the 1 centimeter. And if it's a primary pneumothorax, according to the British, this is according to British guidelines, because the Americans, I think they take it from the apex. But in the UK, we measure pneumothoraces at the hilum. And if it's less than, so if it's 1 centimeter, if we use this algorithm, the patient was 30 and they were not breathless. So this is a primary pneumothorax. It's not greater than 2 centimeters and the patient is not breathless. Therefore, we can discharge them. So well done to those of you who said discharge. But the slides will be then. You can go over this whenever you can. Diagnosis. Tension pneumothorax, good. You've got the pleural edge here, loss of lung markings here, tracheal shift to the right. This is a tension pneumothorax. But remember, tension pneumothorax is a clinical diagnosis. If you're on A&E and you suspect a patient has tension pneumothorax, don't get a chest X-ray, just start treating them. Because the time it takes for them to get the chest X-ray is the time it may take for them to go into a cardiac arrest. So just stick a needle in and you'll hear loads of air whistling out if they do have a pneumothorax. So yeah, we've got rightward tracheal shift. Okay, good. Now we're going to finish up on a rapid fire round and we're going to go through just spot diagnoses. And we're going to go over all of those abnormal cases I showed you at the beginning. So abnormality, just put it in the chat. Hopefully it won't be more than 5 minutes. So I apologize for running over. Good, pneumoperitoneum, there's air under the diaphragm here. That is not normal. That suggests the patient has had a perforation. They've perforated a bit of bowel and that's released air into the abdomen and that collects under the diaphragm. That is known as pneumoperitoneum. If you miss this, the patient will deteriorate and become seriously unwell. So one to not miss as an F1 or a, in your first year of physician associate studies. Abnormality. Any takers? We've got a couple of answers. Okay, tricky one. Pulmonary edema. So well done, AM, for getting that. Bat wings appearance. Yeah, very prominent fluffy hilum. You can see quite prominent vessels in the upper lobe. You can see septal lines if you look very carefully, or curly B lines. Sorry, they're called septal lines as well. Although this is a PA film, okay, this is a PA film, the heart looks enlarged, the heart's massive. This is all in keeping with pulmonary edema. So look how big that heart is. That's not normal. Remember, we're looking at the normal films, the heart was way smaller than that. This is a PA film, if you look at the top. So we can assess heart size here. This is classic of pulmonary edema. I don't think they have a pleural effusion, but just because they don't have a pleural effusion doesn't mean they don't have pulmonary edema, okay? Ooh, okay. Abnormality. Look very carefully. Remember, always look at what do you look for first? So that's my hint. You always look for lines and metalwork first. So think about what this could be. So we've got effusion. So if you see white, okay, interesting. Lay back to me. Very interesting. Okay, the surgical clips at the top and the patient has something going on in the right lower zone. This patient has had a right lower lobe lobectomy. The reason it's not an effusion is because effusions typically appear rounded with a meniscus. So this is very flat, okay? And with the surgical clips, this suggests the patient has had a right lower lobe lobectomy. If you said right lower lobe collapse, that could potentially also be correct, but it doesn't usually present like this. It normally presents with that triangle shape. So right lower lobe collapse presents with that triangle shape that we saw earlier. Abnormality. So we've got left lower lobe and right lower lobe collapse. But look at the costophrenic angles, look at the hemidiaphragm. It's a bilateral pleural effusion, okay? So remember, collapse on the right lower lobe presents with that triangle shape. It presents with a triangle shape, and the left lower lobe collapse, we didn't have an example of that. That also presents with a triangle shape called the Sale sign. These are, you've lost your costophrenic angles. You've lost that nice curved hemidiaphragm. This is a bilateral pleural effusion. Okay. Yeah, I agree. It's not that meniscus shaped. That's probably because it's quite small, but there's nothing else that it can really be. Because remember, I said collapse has that triangle shape. So that only really leaves an effusion. Smaller effusions can appear a bit more straight. Okay, let's just, we'll wrap it up there. We can go, okay, let's do this one. Oh, I already gave you away the diagnosis. Okay, never mind. But if you look at this film, what I wanted you to pick up, the patient has a fractured humerus. Okay, so I'm sure I would have also done this. Actually, I did do this because I reported this film and I looked at it. I missed the fact that the patient had a fractured humerus because sometimes you get too focused on the lungs and then you miss things in the bones. So if you look at this right humerus, there's an irregular line there. They fractured the humeral neck. So always look in the peripheries. Remember the approach. These are the high yield cases they'll ask you in your exams. We'll cover more of pneumoperitoneum and infection in the next lecture, and we'll go into consolidation in depth in the next lecture. So stay tuned for that, and please fill out the feedback form, and I will try and send you a link. If you have any questions, do pop them in the Q&A and I'll try and get to them. You're all very welcome. I'll be most grateful if you could fill out the feedback form using that QR code, but let me post the link. Hopefully that works. You're all very welcome. I will do some, or Azim will do some basic CT head next session, because that's all you really need to know for your finals. You wouldn't be expected to do things like CT chest or CT abdomen pelvis. You just need to pick up basic CT head bleeds, and we will go over that. Some questions I can see. What is the Sale sign? So the Sale sign, Google it. It's a sign of left lower lobe collapse. And if you go back to our right lower lobe collapse example, it looks quite similar to that. It's like a triangle sort of sail-shaped sign behind the heart on the left side, and it signifies left lower lobe collapse. So what would right middle lobe collapse look like? So right middle lobe collapse, it doesn't, so again, Google it, but you don't necessarily lose the right heart border. And in fact, it's quite subtle. So if you Google it, you'll see what I mean, but it's quite a subtle finding.